Hello, good afternoon everyone, and welcome to the webinar, How to Save a Life, Naloxone 101. I'm sorry, 101. We're glad that you've joined us today. You know, I'm just going to give you a quick statistic just to point out how important it is for people to understand how naloxone works and how to administer it. In 2016, there were more than 63,000 drug overdose deaths in the United States. So, you know, what we're going to learn today, I think, you know, all of us will be able to put to good use. So if you need captioning, you can click on the link in the chat box. This webinar is being recorded. So I'm your host, Susan Halpin. I'm the Education and Outreach Coordinator for the New England region of the National Network of Libraries of Medicine. I'm located at the University of Massachusetts Medical School in Worcester, Massachusetts. This webinar is going to last about 45 minutes. If you have questions about what you're seeing or hearing, you can jot down your questions, and we'll save the last 10 to 15 minutes or so as a time for you to ask your questions. I want to take just a couple of minutes to explain about the National Library of Medicine for some of you who may not be familiar with it. The National Library of Medicine is a physical library. It's located on the campus of the National Institute of Health in Bethesda, Maryland. It's the largest biomedical library in the world and one of the federal government's largest providers of digital content. The library is open to everyone and the resources are available to everyone. The mission of the National Library of Medicine is to advance the progress of medicine and improve public health by making health and medical information accessible to everyone. The National Library of Medicine carries out its mission through a national network that has about 7,000 members. These network members are librarians, healthcare providers, public health professionals, educators, students, researchers, first responders, and consumers. And last year, the network provided training to about 77,000 people. I wanted to just point out some fabulous resources that the National Library of Medicine has for substance use disorder. On your screen are some of the links to these resources. We'll also provide this information to you when you get the recording link for this webinar. Now I'd like to turn this presentation over to Frank Malorani and Bonnie White. Frank and Bonnie will tell you a little bit about their background and the work they've been doing, training students and the community about opioid addiction.
Okay. First of all, I want to say thank you to Susan Halpin for inviting Bonnie White and myself. My name is Frank Malorani. I'm Associate Professor of Business at the Massachusetts College of Pharmacy and Health Sciences in Boston. And we have been working on spreading the knowledge about how to recognize and respond to an opiate overdose to our students and our staff and faculty, and we've trained about 2,500 of our students and faculty and staff so far. And this year we're focused on expanding the training outside of outside the university, and so this is a great opportunity for us, and we're very thankful to Susan, the National Network of Libraries, and to listening audiences. So, Bonnie, do you want to introduce yourself?
Hello, everyone. My name is Bonnie White, and I am also employed by MCPHS University. I am a professor of nursing and the interim assistant dean of the DNP program.
Okay, so I think we want to disclose, both Bonnie and I want to disclose that we have no actual or potential conflicts of interest in relation to this program or presentation. Okay, so this is Frank Malorani again. So I'm going to go through the first section, and then my colleague Bonnie is going to go through the hands-on training. So our objectives today can be boiled down to the following. We want to make sure that you walk away knowing how to recognize the signs of an opiate overdose, learn the 5 simple steps that can help save a life, including how to administer naloxone, learn a little bit about naloxone, how it works and where to get it, and then understand the Good Samaritan laws and that protect bystanders from administering naloxone. So let's start with a background. So if you could go to the next slide. So opiate use disorder is a disease which impacts many countries, but the United States is an outlier by a significant amount. According to the CDC, 115 Americans die each day due to an opiate overdose. And nationally, those numbers have been getting worse for at least a decade. Last summer, there was a study that was done by the Harvard School of Public Health. They did a survey of 10 leading researchers, and their worst-case scenario said that if we don't see a dramatic change in events, that we could be on a rate of seeing 250 people a day die in the United States within 5 years. So let's hope that doesn't happen. So since 1999, so in addition to 115 people dying on a daily basis from CDC data, since 1999, when this epidemic really started to take off, the CDC estimates that more than 400,000 Americans have died due to an opiate overdose. And frankly, as sad and terrifying as those statistics are, deaths are really the tip of the iceberg. It's estimated that there's somewhere between 2 and 3 million Americans who suffer on a daily basis from an opiate use disorder. And we'll talk a little bit about that briefly. But that said, this is a chronic disease like many others, and it can be both prevented and treated. And with the right commitment and the involvement of everybody, I think we can start to bend the curve. So I'd like to remain optimistic that things are going to get better and not go to that point of the worst case scenario. So could we go to the next slide, please? So this next slide is a picture of the national overdose rates. So you see that different colors on the map. The blue being where it's above average, the green being below average, and then the lighter blue being around average. But at the end of the day, I think we have to recognize this disease does not discriminate. The death toll from this disease is widespread geographically and demographically across the United States. So we've had other drug epidemics where it's been concentrated in lower income communities. This is not concentrated in low income communities. In fact, the white middle class population is probably hit at a higher rate than a lot of other demographics. So that said, as bad as it is, without naloxone, which Bonnie White's going to talk about, some estimate the death toll might be 2 to 3 times higher. So we know anecdotally that about the number of rescues, the number of reversals of overdoses, but there's no hard record that anybody is able to keep on overdose reversals, because a lot of times the overdose reversals are done by bystanders, and they have no means of reporting that into a database where first responders can. So I'm certain that more than a few of you listening now have known this disease firsthand with a family member, friend, or neighbor. So one thing that you should know is you're not alone, and you don't need to be ashamed. As many of us who have lived through this, we have those feelings. So if we could go to the next slide. And this one is, how did we get here? So, I think we would agree it's essential that we know the root cause of any problem, to ensure that we focus on the right issues. I'm a big fan of the Toyota production system, and when they want to get to the root cause of a problem, they say, ask why 5 times. So, but that aside, you know, there's been a lot of research in this area. Johns Hopkins and others have developed a hypothesis that this problem originated for 2 key reasons. The first in their hypothesis is that pain was recognized as the 5th vital sign in the mid-1990s by the American Medical Association. And as a result, healthcare professionals feel an ethical responsibility to address this subjective problem. So if you're familiar with the vital signs, the first 4 are all objective measures. This is, if you've been to a doctor's office and they've asked you about pain, you'll see the smiley faces. And, you know, so it's a very subjective thing. But so talking to my primary care physician, who can prescribe opiates like almost every primary care physician can, he says he has no way of knowing if somebody says they're at a 10, what that really means. So he's inclined to, you know, try to ethically try to address the problem. And so in addition to this ethical problem that the physicians face, you know, state laws and ethical guidelines begin to enable high level of opiate prescribing. So this all starts in the mid and late 1990s. And coupled with that was by what most of us believe is misleading and unethical sales and marketing tactics by certain pharma companies who will go unnamed, but they were very effective in persuading prescribers and other healthcare professionals that opiates were not as addictive as we know they have been for centuries. So the National Institute on Drug Abuse study that was done in 2015 found that about 1 in 3 Americans used prescription opiate killers and opiate painkillers in 2015, despite the growing concern these medicines are prompting about widespread addiction and overdose deaths. So specifically, and this I find astounding, but this is based on research, nearly 92 million U.S. adults, or about 38% of the population, took a legitimately prescribed opiate like OxyContin or Percocet in 2015, and that's according to results from the National Survey on Drug and Use in Health. And this should come as no surprise, but no other country comes close. We're off the charts when it comes to how we hand out opiates and legitimate prescription opiates to people. So, okay, next slide, please. So the next slide is about opiates and addiction. So given how plentiful opiates have become in the U.S., it should be no surprise that an estimated 4.3 million use them, but people use them for non-medical reasons. Studies consistently show that 80% or 4 out of 5 people who use heroin start with a prescription opiate, and then they need to move on, you know, for cost reasons, for access reasons. You know, I don't think we've ever come across anyone who says, I'd like to start using heroin, but usually it's out of need. So opiates include a plethora of substances, including heroin, OxyContin, Percocets, morphine, codeine, methadone, fentanyl, etc. And as I said before, no one ever takes an opiate with the idea of wanting to become addicted. Addiction, as you may know, is a disease that changes the brain chemistry in some people, so that even after a few days of taking an opiate, those whose addictive gene gets turned on are impacted by constantly craving and thinking about the substance. So, so the other thing to know about opiates and their strength, it's important to know that anyone who puts an opiate into their body in any form, smoking, swallowing, or injecting, is vulnerable to an overdose. So it's not just an injection issue. You can overdose in other forms as well. Next slide, please. So fentanyl is really at the core of the current overdoses that we're seeing. So in Massachusetts, which is where we're located, the Massachusetts Department of Public Health data indicated that 75% of the opioid overdose deaths last year in Massachusetts, which are around 1,800, 75% of them had some degree of fentanyl in the substance. And when we talk about this type of fentanyl, this is not the medically prescribed product. This is the synthetic substance that can come in pill or powder form that's easy to manufacture, costs very little, and is easy to transport. So it's not just powerful, but it's also fast-acting. Usually, opiates, if someone's going to have an overdose, there's a time lag. It might be a couple of minutes, it might be a couple of hours, it might be a little bit longer. But with fentanyl, it's, in many cases, it can be almost instantaneous. So fentanyl is 100 times more powerful than morphine, and carfentanil, which is also on the market and mixed in some cases, is considered to be 10,000 times as potent as morphine. So we're dealing with an extremely potent and dangerous disease. So next slide, please. So the last thing I'd like to talk to before I turn it over to Bonnie, and she'll go through how to recognize and respond to an overdose, is some of the major priorities that are going on. And one of the reasons why I personally am optimistic that we will work our way out of this problem. So there are many strong and significant activities going on at all levels. I talk to people at the community level, the municipal level, the state and the federal level, and there's lots of interest and action that's being carried on. And so one of the largest challenges we have is to educate ourselves and others that this is a chronic disease, like diabetes or hypertension, and no one sets out to become addicted and develop an opioid use disorder. So removing the stigma, recognizing this as a chronic disease, will allow individuals and families to come out and get the treatment they need and deserve. We also should recognize that this disease can be prevented. It can be prevented through education, alternative therapies, and reduced prescriptions. And for those people who develop an opioid use disorder, there are highly effective treatment which is very difficult in many states to obtain, but Medicaid-assisted treatment like methadone, like Suboxone, has been highly effective in helping people into recovery. So with that said, I'm going to turn it over now to my colleague, Bonnie White, who's going to walk you through the steps.
So what we're going to focus on next is the use of an overdose reversing drug, and particularly we're going to talk about naloxone. Okay. So we're going to review the steps to recognizing and responding to an opioid overdose. So let's review the signs of an overdose. The individual may have blue lips or blue nail beds. They may be dizzy or confused. They may be unresponsive. They can't be woken up. They don't respond to questions. They may be making choking or gurgling or snoring sounds. They may not be breathing, or their breathing may be very slow, shallow, and weak. If they do respond, they may have difficulty staying awake. There are 5 essential steps to save a life when you respond to an overdose. Okay. The first is you need to evaluate for signs of an overdose, all those things that were just discussed. Okay. Those would be indicators that someone has likely had an overdose. If an overdose is suspected, the first thing you should try to do is to arouse the person or get the individual to respond to you, okay? You can do this by taking your knuckles and rubbing vigorously on an individual's sternum. In the brief video clip, you saw the woman rubbing her knuckles on the individual's chest. If you do this quite vigorously, the intent of this is to trigger a pain response. It is painful when you do this, and if a person is responsive, they're going to let you know that they're experiencing pain. You can also do the same thing by taking your knuckles and rubbing them vigorously across the upper lip. This would do the same thing and is intended to elicit a pain response, okay? If the person does not respond, the next step is to call 911 for help. When calling 911, you need to be aware of where you are. If you are inside a building or in some type of an organization, sometimes you need to dial 9 or another number to get an outside line. So it's really important to know how the telephone system works wherever you are. You can also call from a cell phone. It is very important when you call 911 to also be aware of where you are located, because it is important to be able to direct people as close as possible to where you are. So the second step in recognizing and responding to an opioid overdose is to call 911 for help. If you have access to naloxone, administering naloxone would be the third step. And we're going to go over in more detail how you would do this, okay? The next step would be to assess someone's breathing. Because someone who has experienced an overdose may not be breathing, if you have the skills and the ability, you can assist with breathing by performing what is known as mouth-to-mouth breathing, okay? Not everyone is prepared to do that. Not everyone is willing to do that, okay? If you are and the person is not breathing, then go ahead and support the person's breathing, okay? The next thing would be to monitor the individual. How are they doing after they've had naloxone? While you are waiting for 911 to respond, you want to stay with the individual. You want to continue to monitor their response because you may need to take additional steps. So we talked about stimulating. So just to reinforce that, you would take your knuckles, you would rub it on the person's sternum or the upper lip. You would also want to call out to the person, you know, are you okay, are you okay? Maybe tap their shoulders. Anything that you might say or do to try to elicit some type of a response. If there is any type of a response, you might want to find out what's happened. You might ask them, you know, did you take something? What's the matter with you? But it is likely that if somebody has had an overdose, they're going to have minimal ability to respond. Okay. We talked about 911. You want to be able to give as much information as possible, so you want to describe what you see, that you're with a person who has stopped breathing, or their lips are blue, or you can't wake them up. You want to give as much information as you can. You also want to give a description of your address and where at that address you are located. If at any time you need to leave the person to make that call or to assist with getting help. If you have to leave the individual, you want to put the individual in what is known as a recovery position. And recovery position is a side-lying position. You can see that one knee is bent so that it serves as a prop to hold the individual on their side, and one arm is extended, which also serves to keep the individual in this position. Okay? If you have to leave the individual for any time, you want to leave them in the recovery position. The reason for this is someone who has had an overdose, they may vomit. And if they are in this position, it allows drainage of the vomit rather than if someone is on their back, any fluids may get into their lungs and create a situation called aspiration. So the recovery position is to prevent somebody from aspirating if they vomit. The next step is to administer naloxone if you have it. We will talk a little bit later about obtaining naloxone. So at this time, we're going to assume that you have naloxone. It's also known as Narcan, and it should be administered to any person who shows signs of an opioid overdose or when an overdose is suspected. And those signs are the ones that we just discussed, the blue lips or nail beds, the shallow or absent breathing, the unresponsiveness. All of those things are considered signs of an overdose. If that is what you see, you should administer naloxone if it is available. Naloxone is a medication that has been used for years by emergency medical services personnel. Okay, it is not a new medication. It is something that has been in existence for a long time. What is fairly new is the public's ability to obtain naloxone and to administer it to respond to an overdose. If a person is given a dose of naloxone, after 2 to 5 minutes, if they do not respond or begin to respond, they can be given another dose of naloxone. There really is no harm from giving multiple doses, and because of the strength of the drugs that are now available and the heroin that may include fentanyl or other combinations of medications going forward, they may not respond after one dose of naloxone. They may need multiple doses in treatment over many hours before the overdose has been fully addressed. So it's really important that you stay with the individual, that you continue to monitor them, and if you have another dose of naloxone and it's been 2 to 5 minutes and the person has not responded, you can go ahead and administer another dose. Presently, there are 4 FDA-approved naloxone products available. Okay? One of them is for nasal administration. This product is also nasal Narcan. This is a multi-step process where this is a single-step process. Okay, this is an auto-injector, the FZO auto-injector, and the original administration method for naloxone that was done by emergency medical services or hospitals would be the vial of the medication administered intravenously or intramuscularly by a healthcare professional. So I'm going to show you a little video clip. It's about an 8-minute clip that goes over these different types of administration devices. And the reason that we show you all 4 is because depending on where you are located in the country, different forms of naloxone may be dispensed. So we want to make you familiar with the 4 different forms because depending on where you're located, you may be able to obtain one of these products.
Try and get the volume up.
It can be really difficult in an emergency situation to remember everything that you may have learned about naloxone. So feel free to come back to this video from time to time to review the information here so that you can always be prepared in the event that you witness an opioid overdose. So you've called 911 and grabbed your Naloxone. Now what? This is intranasal Naloxone in a prefilled syringe, and it requires a nasal atomizer for administration. Each box contains 1 dose of Naloxone, and when you open it up, it looks like this. Now the first step to assemble your dose is to remove all the colored caps. So there's 2 yellow caps on the syringe and 1 purple cap on the drug vial. So now that all the color is gone, we can twist the drug vial onto the syringe. And the most important thing to remember at this point is not to push on the vial at all while you're twisting. This causes some of the drug to leak out of the end. So you want to twist without pushing until you meet resistance. And then you'll take the nasal atomizer and twist it onto the other end until you meet resistance. And now your dose is ready for administration. There's 2 important things to remember when giving a dose of intranasal Naloxone. The first thing is that we're going to try and split the dose between both nostrils. This means you're going to give half the dose in one nostril and half the dose in the other nostril. Now, there is no way to accurately measure half a dose of Naloxone. There's no mechanism on the device that will stop you halfway. So you're going to have to estimate, and it's okay if it's not perfect. Just do your best to administer half the dose in one nostril, half the dose in the other nostril. The second thing to remember is to push vigorously on the drug vial when you give your dose. This allows the medication to form a fine mist that is easily absorbed in our sinuses. If you press too gently on the vial, the medication forms droplets at the syringe, and it does not absorb as well in our sinuses. So push vigorously and give half the dose in one nostril, half the dose in the other nostril. Firmly place the applicator into the patient's nostril so that a seal forms, and vigorously push half the dose in one nostril and half the dose into the second nostril. And that's how you use intranasal Naloxone in a prefilled syringe. This is Narcan nasal spray. It comes in a box with 2 doses. You're going to take 1 dose out of the box, remove it from the packaging, and the applicator goes in one nostril, and you're going to depress the plunger with a quick, firm push. When putting in the applicator, you'll want to form a tight seal at the patient's nose so that the medication goes up into the sinuses and does not come down the face. And then with a quick, firm push, you're going to administer the medication. There's no need to depress the other nostril. You can leave it open. And if a second dose is needed, you will apply it in the other nostril than the one that the first dose was given in. And that's how you use the Narcan nasal spray. Injectable Naloxone comes in a 1 milliliter single-dose vial, similar to this one, and it can be given intramuscularly in the patient's deltoid on their upper arm, their quadriceps on the outer aspect of their thigh, or their gluteal muscle on the upper portion of their backside. To prepare a dose, we'll first remove the plastic cap from the vial and grab your needle and syringe. Now, since we're injecting this medication, we want to try and keep the rubber cap and the tip of the needle clean, so avoid touching those as you prepare your dose. Remove the cap from your needle and insert it into the rubber stopper. Now you'll withdraw the full contents of the vial. There should be at least 1 milliliter of fluid and maybe slightly more due to overfill. So withdraw the full contents. Now we'll get rid of any bubbles by sharply tapping the syringe and removing any air so that we're left with 1 milliliter of liquid. dose is ready for administration. Today, I'll demonstrate how to give a dose of injectable naloxone in a patient's deltoid muscle. When giving an intramuscular injection, you'll first remove the patient's clothing to expose the skin. Feel for the bony edge of the patient's shoulder. Place 2 fingers beneath that, and the triangular area here is the deltoid muscle, and that's where you'll be giving the injection. If available, clean the area with an alcohol swab. Then, pinch the muscle to form a firm surface. Insert the needle at a 90-degree angle and inject the dose of medication. Remove the needle and dispose of it properly. Do not recap your needle. Now that the dose has been given, the patient should start to respond within 3 to 5 minutes. However, if they're not responding, it is safe to give a second dose of naloxone in an alternate injection site if you have another dose available. For more specific questions on how to locate an intramuscular injection site or how to choose the correct size needle, feel free to check in with your pharmacist or doctor, and that's how you give a dose of injectable naloxone. MCO is injectable naloxone that comes in a box similar to this, and each box contains 2 doses of active drug and 1 training device. Today, I'll be using the training device to show you how it works, and I highly recommend when you get your box of MCO to open it up, take out that trainer, and give it a try. That way you can see what it sounds like, see what it feels like, and you can always be prepared in an opioid overdose situation. So the trainer is a white cartridge. You remove it from the case, and it starts speaking to you. This trainer contains no needle or drug. If you are ready to use, pull off red safety guard. To inject, place black end against outer side. And as you can see, it does a great job walking you through how to give a dose of naloxone, so all the work is done for you. And that's
moving on to step 4 is to support breathing, also known as rescue breathing. And if someone is not breathing and you have the ability to do this, then the next step would be rescue breathing. You want to position the person on their back, be sure the airway is clear, you want to make sure there is nothing inside their mouth. You want to place one hand on the person's chin and tilt the head back with another hand on the, tilt the head back with your hand on the chin, pinch the nose, okay, and then place your mouth over the person's mouth to make a seal and give 2 slow breaths. So you want to lift the chin, pinch the person's nose, and put your mouth over the individual's mouth and give 2 slow breaths. And watch for the person's chest to rise. If the air is going into the lungs, you will see the chest rise. If you are successful, you want to follow up with 1 breath every 5 seconds. This is just another step-by-step. Pinch the nose, take a normal breath, place your lips over the mouth, blow until the chest rises, and this takes about 1 second. Wait for the chest to fall, and you can repeat 1 breath every 5 seconds. If you are going to do this, if you have the ability to do this, you should use some form of protection, and if you don't happen to carry a mask or any type of barrier device, you can use an article of clothing just to separate your mouth from the individual's mouth. Another part of step 4 is to provide chest compressions if the person does not have a heartbeat. Many people are trained in CPR, and the rescue breathing combined with the chest compressions is known as CPR. You may be able to do just chest compressions. If you have the ability to do that, the person would be on their back, and all that you do to give chest compressions is push hard and fast on the center of the chest. You want to have the palm of your hand on the middle of the sternum at approximately the level of the nipples, okay? Heel of your hand on the sternum, press hard, press fast, okay? You want to be up and over the individual so that your arms are extended from your shoulders down to the individual's chest. And this is a picture that shows you the positioning of the hands and your positioning on the individual's chest. And the final step is to monitor the person's response to your efforts. All people should be monitored for a recurrence of the signs and symptoms because, as we already mentioned, sometimes because of the amount of drug that they received or the combination of drug that they received, they may need multiple doses of naloxone, and this treatment may extend over many hours. So you need to stay with the individual, monitor their response, administer additional doses of naloxone if you have it, and wait for emergency medical care to arrive. And now Frank is going to resume and talk about the Good Samaritan laws.
Okay, thanks, Bonnie. So there's a couple final things we want to talk about before we answer any questions you may have posed online. But one is the Good Samaritan laws. So the Good Samaritan laws exist in many states, and you should check the specifics in your particular state. And we have a link to the laws that have been passed in each state in our PowerPoint presentation. But essentially what they're intended to do is to encourage action by bystanders. So initially when people were having opiate overdoses, bystanders would be reluctant to call because many times they were users themselves and they were afraid they were going to be arrested or get in trouble for whatever reason. And so the Good Samaritan law have been passed to allow people to call without fear of being arrested, even if they themselves have been using drugs. The other reason for Good Samaritan laws is to limit the civil liability that people may feel that they're responsible for if they don't do things properly or if the outcomes are not good ones. So generally speaking, and this applies specifically for people who aren't licensed professionals, so if you're a licensed nurse or doctor, then you have to look at your own requirements, legal requirements. But for those of us who are not licensed healthcare providers, then generally speaking, it will eliminate the civil liability as long as we're acting in good faith. So basically, Good Samaritan laws are designed to encourage action, encourage bystanders to remove the fear of being arrested, and encourage those of us who may be concerned about civil liability from being protected for that. Okay, so that's one thing. So the last thing that we'll talk about before we look at questions is access to Naloxone or Narcan. So in many states, in Massachusetts being one, and in many other states, there's something called the ability to access Naloxone without a prescription. Okay, so this is done by creating a standing order. So a standing order basically says that a pharmacy can dispense it without a prescription, because Naloxone today is a prescription drug, and that it's a prescription drug in all 50 states. However, because of the urgency of trying to get this into people's hands, most states have taken action to allow easier access, to allow you or I to walk into a drugstore and to ask for Naloxone without a prescription. In Massachusetts, and I assume in most other states, but I don't know for sure, our insurance typically will cover the large portion of the cost, and then you know whatever copay you have. So getting access to Naloxone at your local pharmacy exists in most states without a prescription. And in addition to that, there are a lot of nonprofit organizations, particularly in urban areas, where you might be able to go in and they may be able to dispense naloxone to you as well. So, and there's a slide here in terms of the different laws and protocols that different states have on access to naloxone. Okay, so at this point, I think we'll open up to questions, and we're not going to do questions verbally, but Susan, do you want to talk about how people?
Sure. So if you have some questions, you can type them into the chat box. And, you know, maybe while we're waiting for people to type them in, Bonnie has some frequently asked questions that she can read.
So, can naloxone be used to reverse all overdoses? And the answer is no. Naloxone is only effective in an overdose related to an opioid. Okay. And the next is, can naloxone reverse an overdose involving buprenorphine products, also known as Suboxone? Okay, it can, but it's not going to be as effective if it was just a singular opioid, okay? But like many of the overdoses now, when there is an overdose, there may be multiple drugs that are involved in the overdose, so larger or repeat doses are required. So we have a question. I have heard that you have to be careful with someone who is coming out of an opioid overdose. They might be dangerous. Is that accurate? You are absolutely right. It is difficult to predict how someone will react when they come out of their overdose. They might be very agitated, they might be confused, they might be somewhat aggressive, and they might be angry that their high was taken away from them. So after you administer naloxone and you are monitoring the individual, you do want to put some space between yourself and the individual as they start to respond, because their response can be unpredictable.
Yeah, so I think one of the things that often happens is that people are disoriented. So it's really important, if you have administered naloxone and somebody has responded to it, that you tell them exactly what happened. And oftentimes, just their knowing what's happened, will alleviate any concerns they may have.
Bonnie, I have a question. Do people have physical reactions to the naloxone? Like, does it make them vomit or give them diarrhea, or do they?
The medication itself has very few side effects or very few concerns. It's a medication that is generally very well tolerated, regardless of the amount of it that's given. So it is considered an extremely safe medication to use. If someone is unresponsive, anybody who's responding is not going to know for sure what is the cause of that person being unresponsive. The medication is safe enough that people are encouraged to give it if they even suspect. And very often, if someone is not responsive, we're not going to know for sure what is the cause. So if you suspect that it's an overdose, you should treat it as an overdose. We have another question. What if someone has an allergic reaction? And while it is possible to have an allergic reaction, it is not something that happens frequently. And if someone has an overdose, they may die. So you still have to treat it. And the means that you have to treat it is naloxone. Another reason why you want to make sure that you call 911, that you get emergency medical help on the scene as soon as possible, because you're very limited in what you can do. All you have is the ability to give naloxone. You don't have the ability to manage other medical conditions. But if the person is not breathing, that overdose needs to be reversed. If an allergic reaction should develop, and there's not much information that I've seen that it is a problem, then you would treat EMS can treat the allergic reaction, okay? What if you give it to someone who didn't actually overdose but is a diabetic? The naloxone will not harm the person because they're a diabetic. The naloxone is only going to reverse the overdose. If the person is a diabetic, they're not going to respond to the naloxone. Just another reason why you want to have EMS on the scene as soon as possible. Okay.
There's another question.
Is there any reason that you would not give it? I don't know of any. The only reason that you would not give it is if the person wasn't showing signs of an overdose. You know, but if they're showing any of those signs, most people who are likely to respond to an overdose may not be healthcare providers. They can only act on the information they have, and the information they have is what they're seeing. And if someone is showing the signs of an overdose, that blue lips, blue nail beds, shallow breathing or no breathing, if they don't respond, okay, all of those things that were shown in that short video clip where they may have an irregular or noisy breathing, any of those signs of an overdose, if that's what you're seeing, that's what you respond to. And you respond with naloxone if that's what you have. You wouldn't take any other steps to give them fluids or to give them any other type of medications or to treat it in any way. You would administer naloxone if you have it.
Yeah, it's a very low risk, high reward drug, and you know it can be given to a pregnant woman. It can be given to minors. It's actually even been given to animals and reversed overdoses in animals. And the other thing to keep in mind about naloxone, and particularly if you're able to revive somebody, is many of the opiates that people take are much longer lasting than naloxone. Naloxone typically is only going to last, 15 minutes to an hour. And sometimes the opiate, they may kick the receptors off the brain, but if they don't go for medical help, they may find themselves in trouble again if they walk off. Because a lot of times people want to walk off. They don't want to wait until the medical help arrives. But you should do everything in your power to have that person stay with you until EMS arrives so that EMS can bring them to the emergency room, monitor them, make sure that they are safe.
There's a question, why do officers not carry it? And that is something that is a state-by-state situation. Frank and I and Susan are located in Massachusetts, and I know in the community where we are, Central Massachusetts, officers do carry naloxone. Our state of Massachusetts has an opioid crisis going on, and there are many police force and emergency response personnel that are carrying naloxone. So it is something that is determined by the situation in that area and what the state laws and regulations are in that area.
I'll just add to that as well, that if you go back a year or two ago in communities in Massachusetts that are now where first responders are actually carrying, police officers and others, they weren't carrying a year or two ago, partly because of the stigma issue, partly because there was a feeling that, well, this is something that somebody brought on themselves and, I have more important things to handle. But, as we become more educated about this actually being a chronic disease and recognizing that nobody chose to have an overdose, nobody chose to become addicted, that I think people become more receptive to that this is something that they should be doing. So.
In someone who is overdosed, they may not want to go to the hospital. As Frank said, they may want to walk off. And it really is important that you do call 911 and you let the emergency response workers take over. If the person ultimately refuses to go to the hospital, the EMS workers, they have a process that they follow to relieve themselves of liability if somebody refuses to go to the hospital. But if you are responding to an overdose and you have naloxone and you administer it, regardless of what the individual might say about calling 911, or anybody that might be with that person about not calling 911, if you are responding to that overdose, you should call 911 and let the individual or the other bystanders deal with the individual after they arrive. Your responsibility as a responder would be to respond to the overdose, to use whatever means you are capable of using to address that overdose, and then you let the professionals take over from there, the emergency medical response team and subsequently healthcare providers at the hospital. Okay, so it really is important that they do get to medical care. Another situation to mention is sometimes people wear a fentanyl patch. Fentanyl patches are very often used for severe pain at end of life. So because the medication is out there in patch form, someone may be wearing one of those fentanyl patches. And if, in fact, that's the case, you want to get that patch off of them. But you do not want to touch it. You want to cover your hands somehow to pull that patch off the individual, okay? Another frequently asked question is the 3-part nasal naloxone, can it be assembled in advance? And the piece that goes into the nostril, the nasal atomizer, can be put on the plastic holder. That can be done in advance. But you do not want to engage the cartridge with the medication into the device ahead of time, because once the rubber stopper in that medication cartridge is pierced and the medication is exposed to air, it begins to break down. So you do not want to engage the cartridge in the device until you are ready to administer it. With the other devices, the one-step nasal spray, there really is no preparation that is needed. You take the medication out of the package, you insert it into the nostril, and you push the plunger. There's no prep that has to be done ahead of time.
So I want to just talk about something related to this, which is those who are really at high risk. So there are two groups of people that are extremely high risk. One are the people who have been using and then have a period of abstinence. They may have a period of abstinence because they're in a detox. They might be coming out of jail, might be coming out of the hospital. There's a high rate of overdose when people have abstained for a while because their resistance level is lower, and so that's one thing to keep in mind. The other, and this is the highest risk population, people who use alone. So if you know somebody that has an opioid use disorder, you know somebody that's going to use, one of the harm reduction strategies is to plead with them to please use with a buddy, please use in a public place so that people are able to help them in case they do overdose.
We have a question about, does the medication need to be refrigerated? No, it does not need to be refrigerated. It should not be refrigerated. It should be stored at room temperature. Also, you don't want to expose it to extremely high temperatures either. So depending on where you are located in the country, if you have extremes in temperature, you really wouldn't want to keep this in the glove compartment of your car. You would want to keep it more on your person, in your pocket, or in a bag or a purse, because you do want to keep it at room temperature as much as possible. Okay. And we just want to reiterate that the naloxone is a very safe medication to use. That's why the education is, if you suspect an overdose, to use the naloxone. It is, serious side effects are very rare. What is expected, and is the mechanism why this helps, is it does reverse the overdose. So the person who has been given the naloxone is going to begin to experience symptoms of withdrawal, okay? And the symptoms that develop after the naloxone are not related to the naloxone medication. It's related to the physiologic process. Their body goes through because they are withdrawing from the opioid. And some of those symptoms might be that they have aches, that they're sweaty, they may experience diarrhea, nausea, or vomiting. And once again, those symptoms are related to the withdrawal from the opioid and not a side effect of the naloxone. So we had a question about the effects of the fentanyl patch after removal will take quite a long period of time. And that is absolutely true. That patch is intended to be something that is left in place for multiple days. All the more reason why it is important that this person be brought to treatment, that they're treated at the scene with naloxone, but they then are taken to a hospital so that they can have prolonged medical care. So that can't be stressed enough. Because of the types of medications that are out there, we really do need to recognize that administering naloxone by a bystander is just one step of what has to be more extended care and higher level of care in a healthcare facility. Individuals cannot get high from naloxone, okay? They can't overdose on naloxone. So it is a relatively safe drug to use. And an individual, even if they've had naloxone administered many times, they will not develop a tolerance to naloxone.
Yeah, those are the references.
So, yeah. So we have some references here. We thank you for your participation. We thank you for your questions, and we hope that our presentation was helpful. Have a good rest of the day.
Yep, and actually, if you could just advance the slides. So I just wanted to let you know we have 2 more planned webinars, one in October and one in November, and the link is as part of your slides. So, and you'll also receive these slides as part of the recording information that you'll get within the next week or so. And if you could just advance one more time, if you're getting MLA credit, there will be a link at the end of this presentation, and I have to apologize, I'm seeing a typo. The evaluation code is not correct here. So right after the webinar, I'll send out email with the correct evaluation code for you to use. And I think if you advance the slides one more time, that's the information about how to get credit. Oh, there is the evaluation code. It's SUB3SAV. That is the correct evaluation code. And yes, thank you very much, Bonnie and Frank, and everyone who joined us. We hope you found this helpful, and now you know how to save a life. All right, goodbye now.